what researchers are doing here at Utah. And first, I'd like to introduce the first of two faculty who are working on research just directly related to what we've been talking about all day today, Dr. Mark Yandell. He is a professor of human genetics and is also adjunct associate professor in the Department of Biomedical Informatics. He serves as the associate director and chief data strategist for the program in personalized health and has an H.A. and Edna Benning Presidential Endowed Chair. Dr. Yandell's lab engages in some fascinating research at the intersection of molecular genetics and computer science. Ongoing projects in his lab explore the relationships between sequence variation and human disease, and his current research ties clinical and phenotypic data from the Utah Population Database with genome data and genome annotations to understand the genetic causes of congenital heart disease in infants and to develop new interventions. And we're going to turn the time over to Dr. Yandell today, and I'm excited. I think we're going to have a live demo, so this will be good.
Thanks for the opportunity to speak today. Hopefully I'll be able to work this. So I'm going to tell you a bit about some of the infrastructure development efforts currently underway at the University of Utah, and specifically a tool called K that's going to provide us with a computational infrastructure for large-scale precision medicine efforts. The specific goals of the program in personalized health infrastructure development effort are to integrate the Utah Population Database with our enterprise data warehouse, create an institution-wide resource that will enable outcomes analyses, genetic studies, and fuel clinical trials, and thus empower investigators across the institution and nationwide to improve health care. We have here in Utah an amazing resource for precision medicine, our enterprise data warehouse that contains the medical histories of millions of patients in electronic and very readily usable form for personalized and precision medicine efforts. Really, though, the question is how best to put this to work for the goals of the PPH. And so that is very much a technological development effort, and it's very, very much a very big data experiment. And so I'm going to tell you today about a tool called K that takes the contents of the EDW and applies them for precision medicine. Specifically, K, which is an acronym for the Cohort Assembly Engine, can be used for comorbidity discovery, outcome analyses, and cohort assembly. But for reason of time, I'm just going to tell you about the first two. So, comorbidity discovery. Let me start out with explaining what a comorbidity is in the context of the EDW. So we're all familiar with basic medical descriptor terms, diagnoses, and also the idea that those things sometimes go together. So for example, we may suspect that obesity and hypertension commonly co-occur in patients. And so we can ask ourselves a simple question: how often in our electronic medical records do we observe individuals with both hypertension and obesity versus how often we expect those two things to co-occur under a random model, given taking into account also things like age, gender, ethnicity, etc. Now, I don't want to turn this into a talk about math, but this is a relatively straightforward way to quantitate those relationships and also relate them to a probability calculation that would occur at random. And so we can denote a significant computational comorbidity between two diagnoses by drawing a line or an edge between those two diagnoses and labeling it with the probability that that might occur at random within the database. And so we call that a comorbidity for computational purposes. Of course, a diagnosis can have multiple comorbidities. As I've shown here, obesity may be associated with both hypertension and diabetes without complications. And groups of diagnoses may form an interrelated, tightly connected web of diagnoses that may or may not be connected to other regions of the database. For example, individuals with HIV infection may have a tendency to develop diabetes, but no immediate association with something like obesity. A next natural question we might want to ask about our data is, can we discover temporal associations or pathways that patients tend to take? Once you've been diagnosed with X, are you more likely to get Y or Z? Again, very simple questions can be asked of the data. Does diagnosis I tend to precede J? And if so, does it happen more often than we'd expect? If it does, we can order that relationship. So for example, individuals diagnosed with HIV may tend to go on to develop hepatitis. Or individuals that have diabetes without complications may go on to develop complications. Relationships can be complicated, though. They can essentially be bidirectional, whereby you may have patients diagnosed with obesity that go on to develop diabetes, but also patients originally diagnosed with diabetes that tend to go on to develop obesity. Likewise, comorbidities can not only promote one another, they can also inhibit one another. So for example, a prior diagnosis of diabetes with complications may have a negative effect on the likelihood that you'll have a normal delivery. Moreover, associations can be transitive. We can have a relationship between, say, diagnosis of HIV infection, association with other diagnoses that eventually have some positive or negative impact on some other diagnosis. All of this together forms something called a directed dependency graph for the EDW. That's what you're looking at here to get an idea of the complexity of the data. Just stepping back a second, I'd say probably no work of art has ever embodied so much human suffering and pain. But what you would like to do is get at these data more directly. And so just to give you an idea of the complexity here, as we begin to zoom in, each one of these circles here is a diagnostic, a procedure, or a medical prescription, and the lines between them represent those comorbidities. And you can see our medical data is very complicated. But at its basis are simply diagnoses, say, that are connected by a comorbidity that may be related to two simple things like HIV infection and hepatitis. And now if this will work, there's an old saying in the software industry, never, ever, ever give a live demo. But I'm going to try that nevertheless. The issue there is we'd like to do more than simply look at that, and we'd like to be able to if I can type here. Let's see here. Actually navigate those relationships. And so what you're going to see here is a tool called K, where we've now stepped into that graph and we're looking at, I don't know why that isn't rendering so well on the screen. You'll have to forgive me. That's why they say never give a live demo. But what you're seeing is what happens to a patient within 90 days of being diagnosed, say, with hepatitis. And you can see here the other diagnoses they tend to get. You can also look at this data over time and see, wow, that is a very strange effect. Oh well. Hepatitis, diagnoses that are occur more than 90 days prior to that diagnosis in the database, and then afterward, with the thickness of the line denoting the relative percentage of patients that have that disease. This would be 18% or more of patients with hepatitis go on to develop some of the things here. All right, so coming back to the talk, how can we use these data for outcomes analyses? And so for a few examples here, we're going to look at acute renal failure. This is an ongoing collaboration with my colleague Man Lee, who is an assistant professor in the Division of Nephrology. What you're looking at here is a bit of that giant graph looking at acute renal failure and all the different diagnoses and medical procedures that flow into that, and then what happens after patients are diagnosed with it. For starters, we decided to look to see if over here in this unreadable list were some of the more widely recognized comorbidities of acute renal failure or risk factors. And indeed they are. These are just a few of them labeled here. What we wanted to do was use this framework to look at the association of those risk factors within the EDW and look to see what their impact on chances of acute renal failure are. And so there are several widely used methods to investigate these kind of phenomena computationally. More older models tended to use linear and logistic regression. There's a lot of exciting work going on in the Scandinavian countries right now using something called conditional random fields. Today, I'm going to show you a computational or an AI approach called a Bayesian belief network that allows us to carry out these kinds of investigations. A quick note of caution, we don't yet know what the predictive value of the observations I'm going to show you today are, but there are standard approaches that can tell us this. We just haven't had time to carry out those analyses yet. We expect that predictive accuracy will vary from diagnosis to diagnosis, but that accuracy can be measured to great precision. So for today, it's probably best to think of these as risk calculations rather than actual outcomes predictions. But looking at some of those known factors for acute renal failure, what you're seeing here is what's called a belief net, looking at those risk factors. So you're seeing each circle here is an actual diagnosis. The human readable names are written out here. And then the edges here, or arrows, represent couplings in the database based on the comorbidity associations between all of those different risk factors. Here we're looking at chemotherapy, and the size of the node here gives you an idea of the relative risk for an individual with chemotherapy, but none of these other associations. If we look at diabetes, you can see the sizes of all the nodes changes a little bit. We have a greater risk of acute renal failure. And if we look at individuals that have both, you can see that the network changes more, and again, a greater risk for acute renal failure. This is just a simple summary table that summarizes those results. If we look at acute renal failure here, over the entire EDW, there's about a 1.4% chance that an individual will be diagnosed with that term. If we look at our comorbidities here, an individual that's been diagnosed both with is undergoing chemotherapy and has been diagnosed with diabetes, they're at a 66% chance of developing acute renal failure. That's a 47-fold increase over the base rate. Moreover, a nice thing about these belief nets is we can break all of these factors apart and look easily at their individual contributions. So an individual solely diagnosed with diabetes, not chemotherapy, about a 25-fold increased risk. Chemotherapy, about an 11-fold increased risk. So next we wanted to look at other risk factors, and what we did is we pulled out of these comorbidities here a few other interesting risk factors to have a look at their relative contribution to acute renal failure, and they're listed here. This is that resulting belief network here, again with acute renal failure. If we look at individuals, for example, that have a diagnosis of cataract, you can see the probability of acute renal failure grows. A diagnosis of hypertensive complications other than high blood pressure, it grows still more. And both, you can see it grows still more. And you can also see, if you've noticed, other risks also evolve here. For example, as you might expect, your probability of developing a chronic ulcer also increases when you have cataract or hypertension complications. And so again, just to summarize that here, that basic risk of about 1.4%. Here, having diagnosis of cataracts increases your risk of acute renal failure by about 6-fold. Other hypertensive complications other than hypertension, 15x, and having both about 24x. There's also more subtle effects exerted by things, for example, like prostate cancer, that creates about a 6-fold increased risk. So none of these achieve the same 47-fold increase that we saw for the two widely acknowledged comorbidities, but I think it does demonstrate just how much more there is to learn about the different risk factors and how they interact with one another to predict patient outcomes. So just a few take-homes here. We've been developing this infrastructure to allow us to discover new comorbidities, and as I've shown you here today. This Bayesian belief network provides easy means to measure synergetic and antagonistic and also additive interactions between them. We can easily control for extraneous factors such as add or cancel the effects of age, gender, race, etc. We can identify patients most at risk for particular outcomes based on their medical history registries. And importantly, we can do so doing the actual billing and diagnosis codes that are used within our clinics, rather than trying to deal with abstract concepts such as high blood pressure. And so we can also do things like investigate interactions between diagnoses, procedures, and prescriptions. I didn't have time to show you, but for example, although the diagnosis for cataracts increases your risk for acute renal failure, if you look at whether or not having a cataract surgery increases your risk for acute renal failure, it does not. And so that ability to tease those kinds apart is very powerful, I think, computationally. We can also identify poorly served populations within our health system and better meet their needs. And finally, we can carry all of these calculations out rapidly, on demand, and at scale. So that's a little bit about Kay. Just to acknowledge some of the people involved with this project. Gordon, Alex, and Sergio are the main engineers. Gordon and Sergio are postdoc. Alex is a graduate from BMI who's working as chief engineer, has produced those nice visualizations. Vic is very much heavily enrolled in the project, who I believe knows basically everything there is to know about a database. As you can see here, there are a lot of faculty associated with the project from a lot of different departments or divisions. I'd like to acknowledge especially Will Deere and Marty Tristani, two individuals that have really helped drive this project forward. Also Dr. Ed Clark, that's been a tireless advocate for us. Kurt Knowlton, Ken Smith, Primary Children's, and also our various avenues of funding for it. Thank you very much.
Thank you. We've been told we have time to take 2 questions. Do we have the mics ready to go around? We'll go here.
Alan Morris. That was very interesting. I'm concerned about a couple of things and like your comments. One is the universe you're operating upon is the database. So it has limits. For example, it doesn't capture the reasons for which physicians do things that they actually execute, and it is dependent upon billing codes. And although you're the second person to say that billing codes are an accurate reflection of what happened to the patient, my understanding is that the people who actually do the billing codes actually try and maximize financial return. So their first driver is not, absolutely valid and precise clinical diagnoses. And so given that, and acknowledging that EMRs contain a lot of noise, a lot of bias, a lot of reflections of human error that are carried out by clinicians and others, how do you deal with that noise and the uncertainties, and what is the ultimate goal of defining these relationships? Are you aiming to alter clinician decision-making or to alter policies about patients who present with a certain profile so that they get certain questions asked that might not be asked? It wasn't clear to me what the ultimate goal is.
So, all right, that's a lot of questions, but I'll try and jump through them real quickly. I think, first off, thinking about the EDW as a source for big data, a real power of these statistical approaches is they tend to cut through that noise. The noise sort of falls out, but bias doesn't fall out, as you pointed out. And so I think the key thing there is a robust statistical approach like we're employing here allows you to quantitate those effects and actually measure explicitly their impacts on accuracy. So the underlying assumption here is simply that from month to month, year to year, and with decreasing certainty, that our overall clinical practice remains relatively constant. So an association that's present, say, from 2010 to 2018 that links, say, cataracts with acute renal failure, more or less our clinical practice remains constant over the next 24 months so that that association becomes an accurate predictor. We don't know yet how that accuracy is for that particular diagnosis, but there are standard and robust techniques to measure that accuracy, and that's now what we're doing. We expect for different kinds of risk and diagnoses and procedures, we'll see different degrees of accuracy, but we will know to several decimal places what that accuracy is. Also, with respect to the question of causation, there's a really great article out there in Forbes about Target and their use of belief nets to basically be able to predict whether or not a woman is pregnant more accurately than a pregnancy test based on what she buys at checkout. So basically, if a woman buys a particular collection of, I think, a handbag, vitamin supplements, and scented lotions, right, they're like 99% likely to be pregnant. Now, obviously, buying that handbag isn't the reason you're pregnant, right? But yet it's powerfully predictive for it. And so that's really, the underlying assumption here. We're not making assumptions about causality. And so finally, though, to address your last point, what we want to do is find those associations so that we can basically fuel clinical studies so that we can come to understand that causality. What is the relationship between, diagnosis X, procedure Z, and outcome A? And why do you see that association? With respect to things like policy, changing overwide medical practice, I think I'd like to see this infrastructure be able to do all those kinds of things. But like all basic computational infrastructures, it's more of a means to so many different people's ends that there's no one individual, no single motive or purpose behind it. We hope to use this approach on an AHA foundational grant to investigate outcomes, for example, with Angie Fagerlund on complex congenital heart disease in the coming months. And so that would be one particular application, but ideally there's an infinite number.
Thank you. We'll call that our 2 questions right there. So, thank you. We now are going to turn the time over to Dr. Guillermo Delfol. He is an assistant professor here at the University of Utah in the Department of Biomedical Informatics. In addition to his research here, he focuses on clinical decision support systems. He also leads the development of health IT standards and open source tools, which have been adopted by most EHR vendors and several healthcare institutions across the United States. Recently, he was awarded a U-24 grant from the NIH and National Cancer Institute to investigate a scalable clinical decision support platform that will help identify patients who may be at higher risk for hereditary cancers based on their family history in the EHR. And Dr. Delfol will now tell us more about this support platform.
Thank you. Let's see if I'm going to be the next victim of this little gadget. We're going to talk about this new project that got funded back in September. So we've been working on it for 6 months now. And the idea is to use clinical decision support tools that we have developed in our department and extend those tools to a specific use case where we basically use algorithms to scan the records of patients and try to find out who might be at a higher risk for certain kinds of hereditary cancer. And we're going to talk about that in more detail. Okay, I passed test number 1. I can move slides. So why are we doing this? And this might be well known by many of you. There's a high prevalence in our population of patients who might be at a high risk for familial cancer, though we have some numbers for breast and colorectal cancer, which is the focus of our research. And especially for younger patients who don't go to primary care very often or as often as other patients, our healthcare system might just miss those patients and not provide appropriate tailored screening for these patients. So again, there's no systematic process in general in place to account for that. So here's the overview. I talked a little bit about that, just a little more detail. And we use the whole strategies to try to use information that's already available in the EHR, that's captured as part of the patient care routine. And that's a peer variable. You know, there's information all over the place in the record. It's pretty noisy. And the idea is to look at family history modules. Epic has a structured family history module where it's designed to capture family history, but that kind of information can be scattered all over the place in the record. You can have that as an entry in the problem list, in the diagnosis list, billing codes. You can have clinical notes, could have a lot of that information. And more recently, a lot of our clinics are starting to ask our patients to provide family history information prior to patient appointments in MyChart. And there's also now a whole range of external tools, apps, and all sorts of resources that patients can use to capture family history. And people are now starting to integrate those tools with electronic health records. Part of this U grant mechanism is the ultimate goal is to for people to provide these tools easy access or free access via open source, and we're using standards so that the software we enable here at the university can be used, integrated with other electronic health record systems at other healthcare organizations. So this is just a list of all the main people working on this project. We have several faculty in biomedical informatics. We have folks from internal medicine, primary care, also Huntsman, genetic counseling, and Intermountain is also part of this grant. Everything we do here at the university, we're going to try to generalize at Intermountain to see if things work well over there as well. So here's perhaps the most important slide, this proposed workflow that we're currently trying to implement. And so we have our population-based algorithm. Like we said, it uses structured data in the EHR, and especially natural language processing algorithms. So we try to find mentions of family history that's relevant for what we're trying to do. The algorithms basically put people on a pipeline, a queue, with individuals that are identified as potentially being at a high risk for cancer. If not, then we basically stop there. If we find any kind of hint that a patient might be at a high risk, the idea is to send them questions through a MyChart questionnaire, which is our patient portal, and try to confirm that information. If that's confirmed, then if the patient says no, or the algorithm finds that the patient is at the same level of risk as the average population, a message is sent to the patient and the primary care provider within the electronic health record indicating that. Otherwise, we use a software called Healthy Planet, which is part of the Epic EHR, to create a dashboard that generic counselors can go through and look at their records and confirm if the patient is actually at a high risk. And then send that message to the patient's primary care provider, so they are kept in the loop. And ultimately what we want is a referral with genetic counseling, and also trying to find the most appropriate screening strategy for this patient. This is just an example of criteria that we came up with that's based on, adapted from the NCCN guidelines. We're not trying to calculate a quantitative risk. We're just trying to see if patients fell into one of those buckets. And that's, again, that's just a subset. So, and that makes our life actually easier. We don't need super complete data to calculate a precise risk. We just need to find the patients who might be at a higher risk. And that means basically fitting into one of those categories. Ongoing work, we're about to finish this. We've done an extensive analysis of family history documentation practices at the U, and as you can imagine, we interviewed people, a whole range of people at 10 UHealth outpatient sites. We found incredible variation in terms of how people document family history, and I think that's not very surprising. The most important is the patterns we found. We found 6 different common patterns that people used, varying from having a medical assistant collecting family history information, and then you have the primary care provider confirming. You have medical assistants doing nothing about family history, and the primary care provider is the main person involved with that. Some clinics are now starting to ask these questions before the patient comes to an appointment via MyChart. Other clinics are using iPads. The message here is that our system has to be designed to account for all these different workflows and not require people to adapt to our system. We have to coexist with any kind of workflow. So this is about genetic testing. So what do we do in terms of genetic counseling? So the idea is to provide those managed recommendations back to primary care to how to best tailor the screening of those patients. You know, we can do genetic testing, and basically the Huntsman Genetic Counseling Clinic would take care of those referrals in collaboration with the primary care providers. In terms of implementation, the idea is we're targeting fall 2018 already to have the first version of the system to go live at one clinic. And part of this process is to really understand how the system works. All the different pieces, all the parts, just like we build a car prototype, we want to make sure every single piece is working correctly. You know, the accuracy of the algorithms, how many patients do we actually detect, what is the workflow that we impose, workload we imposed to the genetic counselors? You know, how many genetic counselors do we need to take care of this kind of model? And the same thing for primary care providers. I mean, how do they take the load of additional messaging that they will receive? And how do the patients react to the messages that they receive to complete those questionnaires and knowing about their risk? And although the goal of this system is, this grant is not to do a formal randomized trial, we are going to roll out the system in a cluster randomized approach, stepwise randomized approach, so that we can make some comparisons, at least to get some exploratory work here, and then in the future maybe do a larger trial. Again, dissemination, everything we try here at the U, we're going to do an assessment at Intermountain to see if our platform can work at Intermountain as well with a different EHR system. Like we said, we are using everything we do is based on standards and open source software. Thank you. Questions?
All right, we'll start with one question for now. So, here, we'll go with Sarah.
So it sounds like your base step is asking. There's multiple buttons. Okay. I was able to use the pointer, though. You guys remember that? So your base step is getting family history information. Now, my mom and my dad both have enormous families, so I have aunties and uncles coming out of my ears, right? My kids have one uncle and one aunt. So the information from a family history is very different in these, two pretty simple pedigrees. So are you able to take into account how big the family is in order to balance how accurate really that information is for any given family?
Right. Yeah, so I think that's why the distinction between calculating a risk where you really need a very complete pedigree versus trying to find hints that people might be at a high risk. We're just looking to see if people fall into specific buckets, and if they fall into one of those buckets, they deserve a closer look. That said, of course, there will be, we believe the sensitivity of algorithms is not going to be very high, because that's one of the reasons. It might miss people with large families. You don't remember, you don't even know that someone had cancer, or you don't know the details well enough to report that to a primary care provider. and we would miss those cases for sure. I think those would need, I mean, there are a whole range of new tools now that are collecting family history that are outside the patient care workflow, where people can take the time and ask their relatives, you remember mom, what cancer did Aunt X have? And you can go and complete that. And those kinds of tools may help augment our pipelines with additional information. But for now, we're going very simple, trying to use what's already available.
Thank you. We'll go ahead, have 10-minute break.